Good evening, everybody. My name is Thara Vidyasagaran, and I'm representing Emory St. Joseph's this evening. My talk today is going to be on non-purulent skin and soft tissue infections. I just realized when I made the slide that the number 8 is flipped sideways. It becomes the infinity sign. I feel like we could go on and on about this topic, but we only have 8 minutes, so let's get started. So we all know that skin and soft tissue infections are common, but why is it such a conundrum in hospital medicine? The first thing is that the heterogeneity of the term. It encompasses so many different things, from superficial to deep necrotizing infections, post-op wound infections, immersion injuries, as well as animal bites. Secondly, with the rise of community-acquired MRSA, there's a lot of uncertainty about the microbe we're dealing with, and it doesn't help that even in deep tissue cultures, we only get results about 20% of the time. Studies across the board have shown that regardless of the antibiotic we use, the failure rate's about 12%, and yet up to 85% of the time, broad-spectrum antibiotics are used. And so we're contributing to the increasing drug resistance, so we really need to do better. Let's take a look at a case. 55-year-old male with lower extremity edema goes to his PCP with redness, swelling, and pain. He's given a prescription for doxycycline. He takes a couple of doses, doesn't feel much better, comes back to the ER. Exam shows a superficial, well-demarcated and raised lesion. The ER physician sends off blood cultures, starts the patient on Vanc and Zosyn. He ends up getting the antibiotics for 3 more days and is discharged on Keflex BID for an additional 10 days. And that's how his leg looks at discharge. So we'll come back to this case in the end and see the things that we could have done better. So which patients need to be hospitalized? Those with comorbidities, immunocompromised patients, those that have failed adequate and appropriate outpatient antibiotics, those who are unable to tolerate oral antibiotics, if the infection is rapidly spreading, and of course, if they are very ill and showing signs and symptoms of systemic infection. Risk factors: diabetes increases the risk 5-fold, and lower extremity edema and chronic skin conditions are risk factors as well. All right, so let's go straight to clinical approach. When we are dealing with non-purulent skin and soft tissue infections, the first question we have to ask ourselves is it erysipelas? And there's a lot of debate about the differences between cellulitis and erysipelas, but we're looking for 2 main criteria. Number 1, is it a raised lesion? Number 2, is it clearly demarcated from the surrounding skin? That's a picture of erysipelas. The IDSA also wants us to be specific about using the term cellulitis and erysipelas for more superficial infections and not to describe the skin that's overlying a suppurative focus. For example, if there's an infected bursa, you would say suppurative bursitis with overlying inflamed skin. So if your answer is yes, it is erysipelas, we know we're dealing with beta hemolytic strep. The PO drugs of choice are penicillin and amoxicillin, and for those with severe life-threatening allergies to penicillin, we would use Keflex, clindamycin, or Bactrim. If the patient is ill and requires hospitalization, really our options are cefazolin, ceftriaxone, and clindamycin's the alternative. If your answer is no, it's not erysipelas, then we ask ourselves 2 more questions. 1, does the patient need parenteral antibiotics? And 2, should we be covering for MRSA? Now, if the cellulitis is overlying a medical device like a vascular graft or a prosthetic joint, then you're immediately going to answer yes to those questions. You want to use IV and you want to cover for both strep and MRSA, and so our options really are Vanc or Dapto at that point. If your answer is no, we can use oral, but the patient has MRSA risk factors, then we can use Bactrim, Clinda, or doxycycline, but remember that you have to add amoxicillin because doxy does not cover strep. If your patient does not have MRSA risk factors, you would be covering for strep and MSSA with dicloxacillin, Keflex, or clindamycin. So we know MRSA risk factors really well. Like with everything in medicine, if it's happened once, it'll happen again. So prior history of MRSA is a huge risk factor. IV drug abuse increases the risk about 15-fold. Penetrating trauma is another one. For community-acquired MRSA, the population we worry about are our athletes, prisoners, military recruits, and men who have sex with men. The IDSA does recommend broad-spectrum antibiotics to cover gram-positive, gram-negative, and anaerobic organisms in deep necrotizing infections. And they actually interestingly recommend antifungal coverage for neutropenic patients with cellulitis. I want to point out here that Clinda looks like a good option for most of these infections, but there is evidence of strep becoming resistant to Clinda, so this is going to present a challenge in the future. This is just the algorithm from IDSA, and it's a useful resource. All right, so what doses? When you see a range of doses, remember that the higher doses are for patients with higher BMI and also with more severe infection. So for cefazolin, it's 1 to 2 grams Q8, ceftriaxone 1 to 2 grams Q day, clindamycin 600 to 900 Q8, and Dapto and Vanc are dosed depending on body weight. For oral option, again, penicillin and amoxicillin are the drugs of choice. I just want to point out that you want to dose penicillin, cephalosporins, and clindamycin QID, and the BID dosing that we use for UTIs and other infections are not going to be effective for cellulitis. How long should we treat for? Again, IDSA actually says 5 days, and then reassess the patient to see if they need longer-term antibiotics. Remember that it can take 72 hours for the infection to respond. So do not escalate your antibiotics in the first 48 hours. Reassess on a daily basis and switch to PO when the patient is clinically improving. Treat underlying causes. Again, the IDSA here emphasizes examining the interdigital spaces for maceration, so we treat that and reduce recurrence. So when should we send cultures in non-purulent cellulitis? Again, IDSA has specific guidelines for the severely immunocompromised patients, those on chemotherapy, those with immersion injuries, and animal bites. This is actually a picture of a patient with a DVT, so you can see that it looks very similar to cellulitis, and so getting a venous duplex in patients with high risk for VTE is reasonable. Recurrent cellulitis is 3 to 4 episodes a year. You want to treat predisposing factors. Typical options are oral penicillin daily or IM penicillin every 2 to 4 weeks. So in summary, if the lesion is demarcated and raised, it's erysipelas and you're dealing with strep, start narrow and don't escalate in the first 48 hours. The recommended duration is 5 days. Switch to PO when your patient is improving. Don't send cultures except if patient has neutropenia or on chemotherapy in patients with immersion injuries and animal bites. Remember to treat predisposing factors, elevate the limb, and look for interdigital macerations. So we'll go back to our case again and see what would have happened in an ideal world. Mr. Erysipelas, our male with lower extremity edema, goes to his PCP for lower extremity swelling and pain. It's raised and clearly demarcated, so the PCP knows that it's erysipelas. He decides to prescribe penicillin. Dr. Bonsal, what dose would he give him? 500 QID. The patient then develops nausea and vomiting, so he comes to the ER. The erythema has now spread to his knee. The ER physician does not obtain blood cultures because he knows they're low yield. He starts him on Rocephin. Dr. Desai, what dose Rocephin? Let's say his BMI is 40. 2 grams Q day, perfect. Daval also remembers to keep the patient's limb elevated and ensures he's taught the use of compression stockings. Dr. Hasaniar takes over the patient the next day, notices he's clinically improved, decides to discharge him on Keflex, and what dose would that be, Reza? QID, and how many days do you want to treat him for? Perfect. And you also notice he has maceration, so you give him wound care instructions and follow up with podiatry, and that's how his leg looks at discharge. So, like I said, these are my references, infinity to explore, but I hope this gets us started. Thank you.